Welcome, everyone, and good afternoon. My name is Leah Winfield. I'm a manager at Leavitt Partners and one of the researchers on this project that we're going to talk about today that has examined serious illness care within ACOs. Thank you all so much for joining our webinar today. As many of you know, Leavitt Partners staffs the ACLC, which is housed at Western Governors University. So I want to thank the ACLC for giving me and my Duke colleagues the opportunity to present some of the work and findings on this webinar, and many thanks to Western Governors University for what they do to advance value-based care. I just have a few housekeeping announcements. Please log on to Zoom to view the slides that go along with the discussion today. We'll also make these slides and the recording available afterwards if for some reason you can't access them right now. We do welcome your questions throughout the presentation, and we've set aside certain opportunities to address them. So please put them in the Q&A icon that you can see in your Zoom platform, and we will get to what we can. So our agenda for today, for the first half, so for the past year and a half, Leavitt Partners and the Duke-Margolis Center for Health Policy have conducted research into how ACOs are providing care for patients with serious illness. And this webinar is about that research. So for the first half of the webinar, we are thrilled and we are delighted to be joined by Dr. Nancy Quinn, and she is the Medical Director of Presbyterian Healthcare Services Healthcare at Home Division. And she will be sharing with us some of the work she and her colleagues have done to implement programs for patients with serious illness at Presbyterian. Our work involved 6 case studies of organizations providing care for patients with serious illness, and Presbyterian was one of those 6. Then in the second half, we're going to zoom out and we're going to give a brief overview of why we conducted this research, what some of our key questions and our key findings were. And for that portion, I will be joined by my colleagues at Duke, Rob Saunders and Will Blesser from the Duke-Margolis Center for Health Policy. I've given a few objectives to this webinar because what we really wanted to focus on was to give you some specific examples that we heard from the organizations that we were able to talk to and who participated in our research about how to start or scale care delivery changes for patients with serious illness, how to navigate some of the shared challenges associated with these delivery changes, and what strategies they had found that had really worked well. So it is my pleasure to introduce Dr. Nancy Quinn. Dr. Guinn is the Medical Director of Presbyterian Home Health Care in Albuquerque, New Mexico. She is board certified in family medicine, as well as hospice and palliative care. She attended medical school and completed her residency in family and community medicine at the University of New Mexico, and a fellowship in palliative care and hospice medicine at Stanford Medical Center. Dr. Guinn has worked as a primary care doctor in a community health center and as a solo practitioner. She is the founding member of Ideal Medical Practices, a national nonprofit group focused on quality care. She is also a past president of the New Mexico chapter of the American Academy of Family Physicians. Where Nancy is the medical director of the Healthcare at Home program is Presbyterian Healthcare Services, established in 1908 as a tuberculosis sanitarium, and it now has developed into a system of 9 hospitals, a multi-specialty medical group, and more than 950 physicians and advanced practice clinicians. It also includes a statewide health plan. And so while Presbyterian has participated in accountable care organization arrangements in the past, it has transitioned to a more general accountable care approach with coordinated care and financial risk through its integration as a payer and provider. Presbyterian operates in a remarkably lean environment in New Mexico, where more than half the population is covered by government payers, and the state has the lowest level of people who get health insurance from their employer in the country. So Dr. Guinn, thank you so much for joining us today. It is our absolute pleasure.
Thank you so much for inviting me. I appreciate it.
I know that the Healthcare at Home division at Presbyterian offers a variety of services for patients with serious illness. These include home health care, palliative care, hospice, hospital at home, advanced care planning, and complete care. And I'm wondering if you could start by describing for us what is complete care and how does it meet the needs of patients who are seriously ill?
Absolutely. I think the spectrum of programs that we offer can be confusing to many people, and they overlap in a number of ways depending on the needs of the patient. Complete Care, as you can see from the slide that has just been advanced, is a program that is focusing on patients who have been identified with having serious illness, functional decline. They are high cost, and they are all insured by a Presbyterian health plan, usually, of course, our Medicare Advantage plan. The program itself operates really as a primary care, urgent care, and frankly, even hospital and home level care for patients. About 700 patients usually is our census in the community. And it pulls in all of the other services that we mentioned as needed. So in other words, if a patient does have a hospitalizable condition, can we use our hospital at home program for it? If they need home health, we can provide it. And obviously, palliative care is integrated in many of the services we offer because it's so important to understand people's goals of care when they're frail enough to be receiving care in the home and make sure that you're really aligning with their goals and their need. And of course, advanced care planning throughout Presbyterian is a high priority. And so we do focus on advanced care planning for our complete care population. About 85% of our patients have a scanned advance directive on file. If you scan the slide, you'll see that there are many key offerings that we make to patients. We have 7-day-a-week medical care via physician, nurse practitioners, and nurses. We have on-call night nurses, 24/7 support, care teams, including, of course, care managers, and a real strong social work team as a component also. The slide describes some of the results we've had of the program, including the fact that we've documented that 16% of our visits are urgent same day, and that's really been a huge factor in avoiding people going to the emergency room unnecessarily when we can offer them services in the home. Patients like this program very much, as do family, and we think it's of high value to them, as indicated by surveys. In addition, it's of high value to Presbyterian healthcare system because it has dramatically affected the cost of care for these patients. That's a huge value also, of course. But the critical thing is it's of value to people in their home and helps them stay home and be served in the home. These are people who are really at the tipping point of functional decline and could easily end up in a more institutionalized setting using the traditional issues of going to the hospital, going to a SNF, and then trying to get back home again, that cycle that people go through often when they're seriously ill.
Thank you for that, Nancy. And I think it's one of the key takeaways that I've always had from learning about this and talking to you as we were doing the case study was just how these programs build on each other, right? How palliative care builds on hospice, builds on hospital at home, and how they overlap and complement, really keeping the patient in the center. And so I'm wondering if you could talk to us a little bit about, looking at the slide here, there's Complete Care Home and there's Complete Care Clinic. And how did you make the decision to expand the home-based Complete Care program into a clinic as well?
There are definitely people who still want to participate in being seen in a clinic, and for them, it's something that they're not transitioned yet to wanting to receive medical care in the home. And for those folks who might actually have as high a medical need and be at as great a risk as our home-based patients, we decided to create a clinic. The clinic is integrating really beautifully with the home program. So we've launched the clinic. It's still in sort of the pilot mode. We've been finding patients and offering the services to them and moving them into the clinic, and then offering really similar wraparound services to those that we offer in the home program, and then using our home services as needed for patients. If someone ends up in a medical crisis, we can offer and trigger our hospital at home program for them, regardless of whether they approach that, whether they're a clinic patient or a home patient. Palliative care, of course, is offered, as well as social work in the clinic also. So it's many health systems across the country are looking at what they refer to as rising risk patients and something like that. And those folks are the folks that we've been screening in order to reach out and offer clinic services to.
Thank you for that. And also just keeping in mind that, you know, it's patient preference too. I mean, some patients want to be seen in the home, and like you said, some still want to come into the clinic. And how, if, right, if
describe these patients as being slightly more stubborn than the folks we see at home. They are really determined to be out in the world, and that's, for them, the choice that they make is to be seen in clinic. So we're happy to be able to honor their wishes.
Yeah, definitely. I think that's fantastic. And does complete care also address patients' social determinants of health?
We certainly work to address them. I've mentioned our social work teams already, and we expect that every patient admitted to complete care should receive a full social work assessment, so that, as well as assessment by their nurse case manager, so we can determine how we can integrate them into programs that already exist at Presbyterian or already exist in the community. Presbyterian has got a really robust wellness community health program that's been launched in the last few years. One of the examples of what we have here is a program called the Food Pharmacy, which is a location where people can receive food to supplement their food in their home to ensure that they have the nutritional support we need. So our patients are plugged into our food pharmacy. We work on helping people find affordable housing, really basic needs like that, as well as, of course, transportation, which is just such a huge need for people. I think it's underestimated often as a barrier for people who are frail in terms of being able to access the care they need. So those are some examples of how we work on social determinants.
Thank you. And I want to sort of take a different approach to this. So your healthcare at home division it's incredibly impressive. And I would imagine it may even be a little bit intimidating for an organization who's trying to start or even expand their own program or their own care delivery changes for patients who are seriously ill. Would you talk to us a little bit about how these programs got started? And with that, you know, what advice you might have for a different organization who doesn't already have these robust offerings?
I often laugh at the idea that this homemade program here could be intimidating. We just literally have been working very hard here for a number of years in our own environment in New Mexico and Presbyterian, little by little, to build things. So I think the critical learning from this is it is incremental, and it was built very slowly. When I arrived here about 10 years ago now, Presbyterian had a robust and long-term home health and a hospice agency. They had also had an inpatient palliative program. Our inpatient palliative program is now about 12, 13 years old and had just launched hospital at home. So we just started building on top of that. The first step was moving into having a house calls program because it was clear that hospital at home wasn't quite enough to address the needs of our patients who were urgently ill in the home. So we campaigned for, and I wrote a business case to create a house calls program. We started spreading our palliative care network in subsequent years into the clinics by testing very small, piloting in a couple of locations and proving value, and then getting permission to expand that program. The home program, obviously, the home palliative program grew out of a similar goal of reaching people in the home and demonstrating really small scale and then getting bigger. So you're going to hear a very similar story always, you know, pilot, prove value, and then expand. I think that's a critical need for anyone who's looking at how to create programs. Another critical need in when you're thinking about what programs are appropriate in your system is to really get input from both your system and your community to understand how you can be of value. We were very aware, because of the needs expressed by our patients who were being seen by our inpatient palliative team, we were very aware of critical gaps in navigating a system and care in the home. And so we received that message from our patients, but it was really critical also to meet with internal stakeholders throughout Presbyterian and take a look at what their pain points were. Often many health systems, and of course I'm speaking to the converted here because this is an ACO group, are struggling around various values-based measures, readmissions, just a ton of issues around capacity and access. And so putting those key pain points from internal stakeholders in the health system together with our patient needs led us to develop programs. And every time I created a business case, I put those two together and offered the potential to address those pain points by building programs. Presbyterian for a long time has been aligned around the risk. Operating in this incredibly lean environment means that we must be able to offer high quality care with often less resources than other communities. And so they're very conscious about being able to figure out the best way to deliver care in efficient enough way so that our health system can survive and thrive, and our patients can survive and thrive. So aligning with those needs is how we built the cases always for each one of the programs as we expanded. But again, you just carve out a little bit and keep growing is what I would say.
Sure, that makes sense. So I'm wondering if I could ask a follow-up question about the business case, because that's been a focus of our research. And then we've also heard from a group of palliative care providers that often palliative care providers have all the heart, but maybe not always the business case. And you've been incredibly effective in building that business case. And so you talked about how it's important to understand the pain points internally, kind of align the business case with the priorities and the strategy of the organization itself. But I'm wondering sort of where did evidence is also a part of that too, and in terms of, what's the value to the patient, and frankly too, what's the cost saving to the system. And so I'm wondering if you could just give any more specifics on the business case, including that evidence piece.
Absolutely. First of all, if folks are already involved in palliative care and are members of the Center to Advance Palliative Care, there are tremendous resources in that website to help create business cases and actually help create the needs survey I mentioned, the needs assessment that analyzes stakeholders. So I do send folks to the CAPC website a lot. One of the other programs we're involved is we're a palliative care leadership center that does a lot of mentoring and training with organizations interested in expanding both in palliative care and also in complete care. So I'd suggest the CAPC for a lot of tools. Now, in terms of the specifics of the business case, I'm going to harken back quite a while ago to one of the first business cases for house calls. And the question really was, what evidence exists in the community that would substantiate the likelihood that a house calls program would lead to cost savings? Back then, there wasn't much. Now you can actually turn to the Independence at Home programs and look at the results from several of those Medicare innovative programs to get some actual dollar amounts, likely dollar amount savings from a program like house calls. I'm just using it as an example. But back then there wasn't, none of these outcomes existed yet. And so I literally went through the literature and found studies, a couple of studies that had been created in previous years. One I think had been based maybe out of Kaiser, and looked at the outcomes in terms of decrease in ED utilization, anything I could scrabble about hospitalization. I found a couple small studies around home palliative services, and I put those together into a projection for what I thought we could achieve internally based on our own internal data on patients going to the emergency room. So it was a combination of looking for benchmark data out in the world and then literally doing the math necessary to give an expectation for how those outcomes would apply to our system. In order to do that, I needed to go ask folks for help. I needed information about what our current rates of ED utilization and hospital readmission were, just really basic data, but I did go hunt around the organization and ask for assistance to get that information, and then put together both a narrative business case and a MPV, a return on investment, spreadsheet to demonstrate what I thought would happen, which did happen subsequently. Business cases are always composed of both narrative and dollars, and I think sometimes those of us who are passionate about patient care forget about those two components being critical. But a business case offers you an opportunity to create a mission statement and a very compelling one-pager to describe your vision that can be backed up with projected cost savings. And then it's always a manual process to actually demonstrate some sort of outcome initially while you're waiting for those great reports to be built. So we do a lot of manual tracking early in our programs. You know, who went to the emergency room, who called first, really basic stuff like that. So we're able to demonstrate outcomes. And then, of course, being somewhat integrated with the health plan has helped, because sometimes I have been able to work with reports writers within our health plan to actually share with us in an aggregated way, because we have to be careful about how we share data, but share with us in an aggregated way trends and costs for our patients. Detail, I hope that was helpful. Leah, is there more follow-up, or did that explain the process?
Nancy, that is incredibly helpful. And, you know, one of the things that the ACLC is about is not necessarily having to reinvent the wheel in every single organization. So I think, you know, the tools you mentioned on the CAPC website, the fact that you went through the literature and combined it with internal data about ED visits, and then how you did the math and presented that, it's incredibly helpful. Thank you so much. And, you know, you have touched on the integrated system and the health plan. And so I'm wondering, you know, if you could also talk about, so Presbyterian is fully at risk for complete care patients, and what does that mean for how you think about the program?
I was just thinking about that in the context of an ACO, because frankly, we are at much higher risk than folks involved in an ACO are, and that I think allows us to be a little more innovative and frankly to invest a little bit more, because being 100% at risk really sharpens the mind. And I was actually analyzing our programs to think about what interventions would be helpful if someone was more concerned about investing in such a complex program as Complete Care Home, and interested in testing a model that was less costly to affect the outcomes for the risk that's shared in an ACO model. And so what I was thinking about, looking at our programs and thinking about what had been of huge value to our patients, I really think that years ago, one of my mentors in my palliative care fellowship said, you know, we did a fabulous job in this country of creating 911. You can call that number from almost anywhere in the country. In about 4 or 5 minutes, someone shows up outside your door to stabilize you and get you to an emergency room. But what we didn't create was a similar program for people who need to stay home and be cared for. We don't have the option for receiving assistance with symptoms or with crises in any other way often than 911. And so I think one of our most valuable interventions has just been one number to call 24/7. Not a care manager who is available from 8 to 5, Monday through Friday, or actually 7 to 4 because they don't work till 5, but literally someone who you can get on the phone to help you, and not to triage you via an algorithm that is set up by a standard triage algorithm, but to actually help you and think through what are the best options for you, and also to help you navigate all these complexities. You know, I didn't get my medicine. I went to the pharmacy and something went wrong. I can't get to the pharmacy. You know, I'm scared, I'm worried. What do I do? I think that, you know, how do I get to home health? All of those navigation questions and all of the underlying understandable difficulty in managing these incredibly complex systems we've built, and just plain distress, can be often answered by someone appropriate on the phone, and having a small care team to start assisting these high needs patients might be the first intervention I would make before I actually, you know, walked into hiring all the care managers, all the acute care nurses, and all the scheduling staff and physicians and APCs that we've hired over the years. You know, so a basic intervention might be a way to start. But being at 100% risk really gives us a huge advantage in the willingness here at Presbyterian to really invest in this program and innovate with very good outcomes also.
Absolutely. It's that willingness, and it feels like that ability and that flexibility, that room to do these kind of interventions. And that's so
Correct.
helpful to hear about that starting place as, you know, of all the things that go into something like Complete Care or your other programs or another ACO's care delivery changes for patients with serious illness. It's really, I think, helpful to kind of target like the impact and just the meaningfulness of that 24/7 number to call, which I can imagine provides a tremendous amount of comfort to patients and caregivers that that's available and that resource exists.
It really does. I mean, I've got great sophistication in navigating medical care, and I've had ill family members, and it's amazing how much trouble it is to get something simple like a walker in the home. You know, it's a huge lift for a family, or a prescription that the pharmacy puts off for a day, that is a critical medicine that if you put it off for a day, someone's going to end up in the hospital. I watch this going by as I'm navigating the system for family members, and I think, wow, we all need more help doing this, and particularly our frail patients.
Yeah, absolutely. And that's a very, you know, a totally relatable experience for most anyone, right? To have gone through that, to that with a family member. So it's a helpful also point to transition to the next slide here and my next question, which is thinking just a little bit broader about some of these, you know, really key competencies, or these really key strategies that you think make Complete Care and make all your healthcare at home services really effective. So one thing that struck me in our previous conversations during the case study interviews was how you talked about, you know, the clinicians in this, and finding the right clinicians is really important. So could you say a little bit more about that, and what are some attributes of clinicians in this type of work?
Yeah, and my own prejudice may be playing into this, but I'm a graduate of a family medicine program in New Mexico that's specialty is rural medicine. So my residency involved being out in incredibly small communities with very few resources, needing to do full spectrum medical care. And it's kind of similar to what we have to do in the home. And it isn't that we don't have any resources. We do have nurses to come draw labs. We have the ability to do x-rays and Dopplers in the home. We can even place PICC lines in the home. Really good resources for folks. But clinicians have to be comfortable operating on their own in unusual environments. It's just being in the home is not a controlled environment. And also managing a lot of their work via telephone while driving around the community. So it is a rare clinician that does this, that enjoys this work and loves it. And when you find those folks, the match is perfect. The same applies to the nurses who care for these patients in the home. Our hospital at home nurses are also our acute care nurses, so they often are in the home doing our hospital follow-ups, which we see every patient discharged from the hospital within 48 hours, if not sooner. And so those nurses will do an assessment in the home. Those, you know, over the years I've watched who gravitates toward this program, and a lot of them are ED nurses. So there's a bit of an edge to the, you know, to the care. It's not a routine care process. They have to be able to assess and think on their feet in very special ways. So it is interesting looking for matches. The nurse practitioners who join us have often gone through both family nurse practitioner and geriatric nurse practitioner programs, but we also hire a lot of nurse practitioners who have gone through an acute care training model and have dealt with really severe illness in the hospital, because they're more comfortable dealing with patients who have very advanced heart failure or renal disease in the home. Yeah, so it isn't, you're stepping outside of the normal process of getting care. You don't have a full clinic support staff with you from room to room. Hospitalists are used to having a CT scanner downstairs, and we don't have one. So really identifying folks who are willing to operate in that environment is critical. They're great folks, and the payback for them is the incredibly beautiful relationships they build with patients, and the fact that they have the opportunity to spend time with our patients, because most of our visits in the home are easily an hour, the same with the clinic. So you're having that space and time to build relationship that's hard, unfortunately, in many of our clinical settings nowadays.
Definitely, and I remember talking to one of your clinicians who was talking about sort of the autonomy and the she felt in this kind of work and in this kind of environment. I think that was in the clinic, but still that a little bit longer time for patient visits and not so restrictive, and really she could provide the kind of care she wanted to in this structure. So I want to pause and see if we have any questions from anyone who's joined us on the line. Again, you can please type those into the Q&A icon feature on your Zoom kind of webinar banner of options. We'd love to hear from you, but and as you are thinking, well, I'll give you a moment to potentially type. But Nancy, I'm also curious about strategies that you have found, that your colleagues have found, for really effectively engaging patients in this care, patients and caregivers. How do you engage patients in this?
Well, when you think about patient engagement in sort of the traditional clinical approach, what you're trying to do at that point is engage folks in managing diabetes differently, or taking their medication, or managing their blood pressure, or something like that. And I think engagement is really different for folks that are coping with this degree of serious illness. And probably, for most of our patients, are within the last couple of years of their lives. So what do you want to engage them in at that point? I think you want to engage them in conversation. You want to know them well enough so that you can help give them medical advice that is appropriate for their care. And so the engagement is around getting to know them, getting to know what value is to them, what gives their life meaning, and to make sure that they get care that really supports that value. The caregivers, it's engaging them around the incredible burdens of being a caregiver to someone who is significantly ill, and understanding what it is that we can offer support. So it is getting to know them, which is why it's so great to do this in the home, right? You're in the home, you've met the 2 dogs, the 4 children are there for that day because they're worried and they want to talk to you about their mom. So they feel heard and engaged. And then of course, again, this is always an interdisciplinary team. So we have our social workers, we have our clinicians, we have our physicians and nurse practitioners, we have our nurse case managers in the home, and we have our acute care nurses in the home. And we also will pull in other folks like palliative care team members to offer us consultative services, and whatever support is appropriate for these patients. Sometimes the best thing to do is to bring in we have a palliative care chaplain who will come in and have conversations to tap into the true pain and suffering that people may have while they're coping with the kind of conditions they cope with. So the engagement is about real conversations, building relationships, and documenting those conversations, and then treating people appropriately for those conversations. So treating people appropriately, giving them the medical care that they need based on what they've told you they want.
Yes, treating people appropriately in that sort of personalized way, and really addressing their medical needs, their social needs, if their spiritual needs, if that's applicable. That's really amazing and really fantastic, Dr. Guinn. I just want to sincerely thank you so much again for joining us today, for the help you've provided on the case study, and most importantly to you and all your colleagues at Presbyterian for the really incredible work that you are doing for these patients and their families in New Mexico. So many, many thanks.
Thank you very much for the opportunity to speak about this program.
Okay, I am going to transition us now, and what we are going to talk about next is what we found in our research. And so, as I said in the beginning, Presbyterian was one of 6 organizations we looked at and that we featured in our case studies. And so we'd like to sort of talk about a synthesis of what we found from all 6. I'll introduce my colleagues from Duke, Rob Saunders and Will, and then I'll turn things over to Will to talk us through some of the research. Rob Saunders is the lead on this project. He is the Director for Payment and Delivery Reform at the Duke-Margolis Center for Health Policy. And in this role, he manages the center's portfolio for payment and delivery reform initiatives, including bringing together faculty from across the university for developing the strategic vision in this area. And Will Blesser is a research associate for payment and delivery system reform at the Duke-Margolis Center. He works with Mark McClellan and Rob Saunders on topics related to accountable care, Medicaid expansion, Medicaid incentive programs for health behavior change, population health, and emerging state health policy issues, among many other topics. So Will, I'm going to turn the microphone over to you, and you can lead us through a little bit of the overview of our research.
Absolutely, and thank you, Leah, for the nice introduction. And my colleague Rob will periodically chime in as well. Just wanted to note that. So just at a very high level on this slide, some of the background for why we were interested in this and why a lot of funders and CMMI and CMS are interested in this space is simply that the frail elderly and people living with serious illness, traditionally their care under a fee-for-service environment falls through the cracks. A lot of the services are not reimbursable, some of the key personnel also not reimbursable, and what happens is their care becomes fragmented or incomplete, and the system doesn't incentivize accounting for their preferences or values, and that includes their caregivers as well. So as part of this approach, we are funded by the Moore Foundation and in collaboration with Leavitt Partners to use a variety of different methods to understand the breadth and the depth of serious illness care programs within ACOs nationwide. And so we wanted to understand the big picture, how many ACOs are doing it, but then find a few with some sustainable success in this space and across a diverse number of states and contracts and settings to understand what they're doing and draw themes across all of them. So that's exactly what we did. On this slide, I just wanted to briefly highlight some of the products that have come out of this. Dr. Nancy Quinn just spoke about Presbyterian Healthcare Services serious illness programs, and that we've written up that information in a case study report that is published on our website, which is linked below, and then a 2-page version of that is part of the ACLC's case study brief series, so you'll see that on their website as well. We have 4 total that have been released, and we have 2 more coming out by June 4th, which will coincide with a paper that we're releasing in Health Affairs, which is shown on the bottom right there, and that will look across all of them as well as some national survey data. And then finally, I'll just briefly highlight, we still have ongoing work in this space. In the top right, just a little teaser, we have some claims data analyses where we're looking at the business case for investing in this population for ACOs and how these patients are performing. So this first slide is from survey, the 2018 annual ACO survey, which was put on by Leavitt Partners and the National Association of ACOs. And we helped to design some questions to go into the survey to ask about serious illness care by ACOs. So this slide is meant to show the overall landscape. And I think the big picture takeaway here is if you look at the left side, you have about 2/3 of ACOs responding, which was about 200 ACOs, indicating that they have widely implemented routine identification efforts to identify the seriously ill, and almost all of them have at least partially implemented that. So that bar shows that most ACOs are aware of these patients and are working to actively identify them. But then if you look on the bars moving rightward, especially the blue-colored ones on the wide implementation, these are specific serious illness programs per se, or components of programs. And those blue bars are quite a bit smaller. So you see in advanced care planning services, providing 24/7 clinical response for these patients, or home-based or community-based palliative care. The wide implementation of those programs is very low, somewhere around 10 to 20%, and the partial implementation is also fairly low. But we think that indicates that if ACOs are thinking about this, they haven't quite made the jump yet. So I wanted to talk about briefly a few of what we're calling cross-cutting themes from all of these case studies, and I'll try to slot in some examples along the way. One of the biggest challenges we saw was simply the cost to scale up these programs, and that can be on top of what we've heard. It could be $1 million investment to stand up an ACO generally. So some strategies we saw were building off of in prior investments made in value-based infrastructure, and one example would be a patient-centered medical home. We spoke with a rural ACO who did this. They had an existing NCQA certified patient-centered medical home, which was their first major steps as a hospital system towards value-based payment. And at the same time, they had identified that across all of their major departments and clinics that they had a lot of care coordination efforts that were occurring in silos, and there was an opportunity to get everyone in the room and reduce redundancies. So that quality effort, combined with the infrastructure of the PCMH, they sort of got together and they built off of that to join the Medicare Shared Savings Program as an ACO with one component of their ACO targeting seriously ill folks who were recently hospitalized. Another opportunity would be, there was a survey released earlier this year that showed that almost all ACOs have complex care management efforts, and we see that as a good stepping stone. So a lot of the programs that we studied were what you would consider to be a higher touch version of a complex care management program. So that could be a major stepping stone. In terms of securing some upfront investment, a couple themes popped out. One we have in quotations there. Oftentimes, an ACO was able to, or one of the ACOs we studied was able to get an upfront capital loan from a parent organization that they were able to then pay back over time using shared savings. We published that in the U.S. Medical Management case study, which came out 3 weeks ago. And then other ACOs, there's opportunities if you're in a smaller physician-led organization or in a rural area that's more resource deprived. There are organizations like Allidaid or Caravan that can help aggregate resources among small physician groups in rural areas. And then finally, we also heard that there are often opportunities to get grants from local foundations that may only be offered in one region or one city. And one ACO we studied, FACE Medical Group, which that case study was released today, their palliative care group had received a grant about 8 months prior to joining the ACO to help them develop some home-based palliative care competencies, and that was crucial to them to be able to join that contract. And there was an interesting debate there, speaking of contracting, on whether the ACO wanted to hire their own staff in-house, and which would allow them to potentially reap more savings, but also have more risk, just want to contract out to another group.
And this is a great summary showing the business case the business case considerations that ACOs are facing. I think one of the challenges that we heard over and over again from many ACOs was that if they have 1 foot in fee-for-service and 1 foot in value-based care arrangements, it was often a struggle. And so they often built their arrangements in a piecemeal fashion, looking at what they could get reimbursed under fee-for-service arrangements. And then as they reaped shared savings, they could then funnel those back in to fund more extensive services. But they had to do it in a piecewise fashion, given some of the challenges in being both in a fee-for-service world and a value-based payment world.
And then next slide, Leah. And that's a great transition on how did ACOs go about building the business case to their leaders and getting buy-in of their staff. Rob had just mentioned one key argument that was brought to leaders was that the ACO model and the shared savings that you can potentially get in the future, those savings can be spent a lot more flexibly on things that would not be reimbursable for serious illness care under a fee-for-service model. So that was a key argument we saw, and we heard from numerous ACOs. We have a quote from one in our case studies that they simply wouldn't, that was key to the argument. They wouldn't have been able to invest in this information people that are we talk about for seriously ill populations. These were particularly important because a lot of the utilization of seriously ill patients, especially in this last 6 months of life, is considered to be not only unnecessary but potentially harmful. So these are also seen as quality proxies, and in pilots they were nice to be able to take to leadership. Further, there was sort of a comfortability argument there that these are metrics that are familiar to the ACO, that they're used to calculating with the data that they have. So that was a convenient use of that. And claims data also comes with a lot of these contracts, I should mention. In terms of trying to pitch for, why should we focus on this population? One ACO we talked to had already become efficient across their general population health efforts, and so serious illness was sort of a place to step into with the recognition that, hey, 5% of our population is potentially driving 50% of cost, so why don't we start there? And then one challenge that some, especially hospital ACOs, may encounter is this whole heads and beds conundrum, where there are incentives for them to keep people in their hospital beds, which could, if you're doing a program like this, which is supposed to potentially reduce those emissions, can cause, obviously a conflict of incentives there. And a few ACOs we talked to specifically noted that their readmissions were being reduced enough such that they were not receiving penalties, or they were receiving reduced penalties on readmissions, and that amount can counter the heads and beds revenue problem. Anything else you'd like to add, Rob? Alrighty, moving on to data and health information technology. For this population in particular, because there's a lot of care coordination involved, sorry about that. There's a lot of care coordination that's necessary for this population, and a lot of schedules, especially if you're doing home-based care. There's a lot of scheduling. Investments in new data systems and new data dashboards was a big investment, and then particularly for identifying this population, it requires some creative use of data and ability to merge multiple data sources together. So one significant effort where data system investment was made was in identifying the population. And it's worth noting that among the ACOs we talked to and from what we've heard in the field, there is no secret sauce to identifying this population, but there was sort of some commonalities in the general approach that they took. And this can be done within claims or within claims data, sometimes adding in some electronic health record data, which again is data that the organization will be familiar with. And the commonalities were generally around, let's find people with a list of severe conditions who also have recent utilization, and there's a couple ways to use claims data to proxy functional limitations, such as durable medical equipment use in wheelchairs or home oxygen. And then frequently they paired that approach, the algorithmic approach, with a surprise question where they asked physicians, would you be surprised if any of your patients died within the next 1 to 2 years? And that combination was often one that worked well. A data theme that popped up that can help serious illness program efforts was having access to a health information exchange. So U.S. Medical Management was one we talked to. They operate in 12 states, and their model is entirely home-based primary care. Some of those states have health information exchanges, and some of them don't. And then among the ones that do, they can vary as well in their requirements. And the ability to detect when a person with serious illness pops into a hospital or a clinical setting outside of your own organization and your ability to receive that in a timely manner is obviously very important. So there's some policy implications here, especially at the state and regional level. But we also heard from ACOs that didn't have access to health information exchanges that said there still can be thoughtful partnerships with external organizations to help facilitate that problem. One example I'll give on creative dashboard development was from New York City Health and Hospitals, which is a public hospital-based ACO in the Medicare Shared Savings Program that we released a case study on today. And they viewed their data dashboard as their most critical tool for the success. So that dashboard consolidates and synthesizes claims data, financial data, clinical data, and utilization data from a variety of sources. They involved clinicians in developing the data dashboard, and they provide snapshots of the ACO population, including chronic condition statistics that can help identify where their patients are at risks or may benefit from palliative care programs, and that was a key driver of success for them. Next slide, please.
All right. Thank you so much, Will. That's really helpful. I'm going to talk about strategies we heard from ACOs around patient engagement. And again, thanks to Dr. Guinn for telling us a little bit about Presbyterian Healthcare Services strategies, and I'll synthesize some of our other findings. And, one thing that I found that was particularly interesting is that, we sort of know that building relationships with patients is important for a variety of reasons, patient satisfaction and clinician satisfaction as one. But one ACO really found that that building these relationships with patients also helped bring down unnecessary ED and hospital utilization. And so, they found with more trust, patients in this ACO serious illness program, they called that, 24/7 number that's available rather than skipping right to 911, or rather than just automatically going to the emergency department or the hospital. And so with that kind of relationship, the ACO the 24/7 number could determine if, that patient's condition and needs could be addressed by a home visit, or if, going to the hospital really was important and necessary to do in that case. And moreover, in this situation, building this relationships means it's more likely for the caregiver or the patient themselves to call their care team and to call their provider if they have been admitted to the hospital. And so this allows, the care team to keep track of the patients and to know, kind of what's going on, and to maybe rethink or redesign the intervention that patient needs. So another ACO that we talked to where the care team provides visits in the home, but it's not really intensive clinical services in the home. So it's not really a healthcare at home situation. What they require of their care team, and the care team is made up of nurse care managers, health guides, and social workers. And so what they require of that team is they undergo a 2-day training just on motivational interviewing. So there's other training related to common conditions that the patient might have, but really this focus on 2 days of motivational interviewing. And on top of that, this ACO requires the care team to shadow a more experienced care team for 3 months. And that's really to learn the best practices from those more experienced individuals. And all of this is meant to just strengthen that relationship and really develop that rapport with patients. One other example related to the care team that I found really, really interesting is that one ACO, they were trying to figure out what was the best place to locate their care coordinators. So they started with what I think is a logical place to start, which is locating all their care coordinators in a central location, sort of in that ACO's headquarter location. But what they found is that when patients called their care coordinators or called into that central location, they often got a different care coordinator every time, or they frequently got a different care coordinator. And so that made the whole concept of coordination a little bit more challenging, and it made relationships difficult to build between care coordinators and specific patients. And so in response to that finding, this particular ACO decided to move their care coordinators into local offices. And so that allowed them to develop these more personal relationships with patients in the area, and especially get to know kind of the high utilizers and sort of what their needs were, and help stabilize those individuals in particular. What we found too from our research across all these different ACOs was that these kind of care delivery changes really allow longer and more frequent visits for patients with serious illness. And so it wasn't unusual among the ACOs we talked to have home visits that lasted an hour or more. And these help to build that trust. They help to see that kind of honest look into the patient's lives. What does their home environment look like? As Nancy said, who are the kids? Who are the dogs? What medications are they taking? What is their food supply like and their access to food? What's, who are the caregivers and how frequently are they coming and going? And, what we heard is that situation just really helps put the patients more at ease, and they can even be more honest and forthcoming with their providers, and really talking about, challenges they're facing without necessarily feeling embarrassed or, feeling kind of more closed off by the clinic setting. And a different ACO, what they found from some internal data analysis was that when they didn't see a patient for 45 days or longer, that patient was more likely to have an emergency department visit or hospitalization. And so what they did with that is they said, okay, we want to see all our patients in, within 30 days or 30 to 45 days, and especially 1 to 2 days of hospital discharge, and kind of, prevent that type of unnecessary utilization that came if a patient didn't receive a visit in enough time. So as we wind down our time on this webinar, I want to give one more chance for question and answer. If you want to type any of those into the Q&A box. And if you do, or as you're thinking, I will just share some upcoming ACLC events and key dates. And so as you can see on this slide, Q3 committees are going to be meeting in August through October. And then Q4 committees will meet October through December. There will be 2 upcoming ACLC webinars based on the Q1 and Q2 committees. So the first on June 26th, and then the second on July 10th. And then, please do mark your calendars for the member event in DC in October. I will highlight too, of course, one of the Q4 committees is on serious illness care. And, we please encourage you to reach out to anyone at the ACLC, John, Daniel, Tom, Kate, if you have questions or if you are interested in that committee. And we're actively recruiting providers for these committees. So please, if interested, do reach out. I'll finish by saying that a recording of this conference call will be available, and it will be included on, we'll be disseminating it through the ACLC weekly newsletter that you receive. And finally, thank you so much for joining us. Thank you, Nancy. Thank you, Will. Thank you, Rob, for presenting. And we hope you found this presentation valuable and that you have a really good day. Thank you.